Thank you so much, sir. Now, may I request Dr. Bibhas Ranjan Kundu, sir, Senior Consultant Urologist, to speak on the topics of how to differentiate Clinico Radiologically, Hilar RCC and Pelvic TCC, my approach on these topics. This will be followed by question and answer session, and Dr. Kunjan Kumar is here. We'll take your suggestions.
I don't know what
Good afternoon. So when I pressed, thank you organizers, thank you Dr. Chatterjee who tried to track me from US and Dr. Gopal. We had a very late night session yesterday and then we are into too much of academics. I was given this topic, how to differentiate clinical radiologically Hilar, RCC and pelvic TCC. It took me a while to realize what I am going to talk about, but let's do some justice to this talk and find out how we can find a common ground, get you some info so that you can have at least something to carry on. Very basics. I always love basics because, you know, these days, these are very foreign terms. I don't know how much of you, how many of you can actually elicit a ballotment. It's very basic. So I was trying to figure out what are the three clinical things that really matters in a real lump. Although the specificity of such findings would be very, very remote. I mean, you cannot, by the charm of your fingers or a history, differentiate between a TCC and RCC. There are some very subtle points like hematuria. So we all know that hematuria occurs in both the situations, but it will be early on TCC, very common sense knowledge. And the classic triad of flank pain, of hematuria and a mass is less than 10%. We used to highlight this too often. The reason I have put up ballotability and bimanual is that these days we don't even have to do this. We get very early tumors which are hardly ballotable and not bimanual palpable. In our times, I'm not that old, but in our times in the 90s, this was a very common presentation, advanced renal cancer with big lumps. And you can figure out, the ballotment is for a lump which you can fill with a palpating hand on the top and you have to ping pong it from the below. And definite third, this is for the lumps that are not bimanually palpable. In other words, they are not so big as you can feel it within the two hands of your palpating, two fingers of your palpating hands. Now, what do you gain out of it? Usually ballotable lumps or large lumps, it can happen to both situations, TCC, RCC, there is no difference. The shape may have a clue. If you have a very round, a distorted shape, doesn't look like a kidney, but it's just a football, which is the usual presentation. Chances are that you are eating a RCC. But again, there is no specificity attached to this statement. So by and large, we have to fall back on radiology to give us what we want to know about this topic. I would just highlight a few points which I thought would help you and to sort of juggle through the statements that a radiologist makes on a CT, and that is very important. Enhancement. Now, if you look up the word enhancement, it means, the English word means brightened. So you have the photo gallery in your phone. You try to pep up the contrast, put some sharpness, some brightness, pep up the picture. So these you can do digitally, but you can also do to the image as well. So anything that enhances the mass after a dye is an enhancing SOL. And now enhancing SOL can be subdivided into a variety of categories which I'll go in later on. And the other term is attenuation, which it means the opposite. It's reduced. So attenuated lumps like an X-ray going through a water will be dark and there will not be much of density in the substance. So there will be low attenuation. So in actual words, attenuation means radio density. So what are the low density stuff? Air, water, fat. You all know AML, classic example, the fat is minus 20 HU, which is what I was trying to make at. So how is enhancement caused? enhancement is caused by actually leakage of the dye around the tumor. Very small leakage. The new vessels, the leak contrast, and that outlines the SOL very clearly in contradistinction to the surrounding parenchyma of the kidney. So enhancing mass which is solid, maybe cystic as well, 85% of the enhancing masses are malignant. And non-enhancing on CT, how do you define it? No increase in the CT after IV contrast. 100 seconds is the maximum limit. If you do not find any enhancement at about 100 seconds from the dye injection, this is a non-enhancing mass. So these are points that you have to keep in mind when you define or write a radiology report. So coming back to three fundamentals: density, fat, and enhancement. Let's see how we can apply them. So hyperdense on an unenhanced CT. If you have an unenhanced mass, it's a cyst. You can verify that with ultrasound or MRI. MRI are very good for picking up cysts. If you have hemorrhagic cysts, it will be hyperdense, which are more than 70 ounce fluid in it. And fat, as I say, AML, extracellular fat, mind you, extracellular fat in AML. You also have fat in RCC, which is intracellular fat. They're very usually lipid poor. And there is also another variant, lipid poor variant of AML. So this you have to really understand. And if you have a hyperdense mass, by and large, they are AML, extracellular fat. Saying the same thing, macroscopic fat means angiomyolipoma. You have to take a thin slice to identify that, but you do also have lipid poor AML, and that is a differential for renal cell carcinoma. But if you have presence of calcification in the fat, that is sine qua non, absolute indication of RCC. Like I suppose any tumor, calcification is there. So a homogeneous enhancement, again papillary, TCC or AML, lipid poor AML. But if you have a very strong enhancement, it means renal cell carcinoma. The TCCs are not very strong enhancing lesions. They are very homogeneous, not very strong. So what are the steps in a mass algorithm for radiology CT scan? We have to first determine whether it's a cyst, then look for macroscopic fat, exclude tumor mimics. I'll go through the tumor mimics that really looks like tumor, infection, infarction, but they have a clinical setting which is different. There is a fever, there are multiple lesions, like metastatic lesions and lymphomas are multiple. So I exclude all that from our discussion because it will mangle too much information and we will not clinch what we have started off to speak. Now again another flow chart to see what we can do with the CT, a renal mass CT with no enhancement, probably is a cyst, confirmed with ultrasound or MRI, macroscopic fat, angiomyolipoma, and the categories of enhancement. It is equivocal, very low, consider TCC or a pseudotumor. Mild enhancement, again some varieties, papillary, RCC, and vivid enhancement is the classic clear cell. That is what we really are looking for. And the T1 and T2 images, which gives you the signals. Signal drop in a T1 is intracellular fat, as in RCC. In a T2 image, high signal means clear cell carcinoma. These are stuff that are absolutes, and there is no. We don't need to go into real detail because we'll see that we are very familiar with the CT and we can pick up a lot of information from the CT scan. Now going through a few aspects before I go into the actual 3 or 4 minutes of what you can do to clinch your diagnosis, we'll do that. There are 3 phases, as you know, 25-40 seconds corticomedullary phase, a nephrogenic phase, and of course excretory phase, like in IVO, like in CT contrast. And each one of them have importance. The nephrogenic phase gives you the vascular involvement. It also gives you the RCC. They are shown very well in the nephrogenic phase. Excretory phase, of course, by a negative shadow shows you the tumor in the pelvis, ureter, etc. This is just a point that I was going to make. Look at the 3 pictures. Unenhanced on a normal, non-contrast CT. Particular middle stage, you can see something not very clear, but on a nephrogenic phase, it's very, very clear. The dye around the tumor has outlined the tumor and enhanced it, vivid enhancement. So you can see this is SOL and likely RCC. Now, this is one of my patients actually. Very carefully look at 2 pictures, 2 kidneys. One with no enhancement, a cyst. The other one on the upper pole, right side there is a tumor on the nephrogenic phase, and probably RCC. Why I say RCC, we will come to that in the next few slides. We'll come and discuss that. There is a variant called papillary RCC. They have a low enhancement, 10 to 15% of all RCCs, and because of the low enhancement, they can be a differential for transition cell carcinoma. It can be frequently bilateral. They are homogeneous and hypovascular. That's why they are confused sometimes with the transition cell carcinoma if they are in the same locations. So locations matter. Another picture of clear cell carcinoma on the CT. Just thought I'll just familiarize you with the CT plate before coming to the actual discussion. Now, this is the classic slide. I hope you carry this home. If you have a ball, it's a renal cell carcinoma. If you have a bin, well, it means the bin is preserving the shape of the kidney. If you look at the lesion on the right side, there is a tumor on the upper pole. It has not distorted the capsule. It is well inside the kidney, and the kidney shape is preserved. So if you have a preserved kidney shape, it's transition cell carcinoma, unless proved otherwise. And RCCs almost always distort the kidney. That's why I was talking about palatability and the shape, which gives you an information, very basic information on the clinical exam. Very large angiomyolipoma can also be a ball type lesion, and the closest differential is oncocytoma. Oncocytoma will fool you all the time. You know that very well. So these are the things. Now, there is no information required other than looking at the tumor, distort the shape, and RCC we don't need to discuss. We are not here to discuss RCC. You know more about it than I do. And so, just give you some pictures of the ball type lesion. See, the shape of the kidney is distorted, and there is a huge tumor here, as you can see there, deforming the renal contour. On the other hand, the bean type, uniform shape is preserved, and transition cell carcinoma comes first on the list. It can also be a renal cell carcinoma, but TCC falls into that category. This is a classic picture where you have very homogeneous, not very enhancing. So it is a mild enhancing tumor with a homogeneous SOL, bean shaped preserved. This is TCC of the collecting system. Also, look at where the tumor is centered on. The center of the tumor is in the collecting system. That's very, very important. TCCs are low grade usually, most of the time, can be very aggressive, can be infiltrating, but it keeps the bean contour. Another TCC, lower pole. The shape of the kidney is preserved, just to show you that, and another one on the other side. It is twice as common in men. We all know the causes, we are not here to discuss them. Smoking, chemicals, drugs. Peak incidence is 6th and 7th decade. Now, this is a picture I have taken from the Indian Journal of Urology, a publication by Bibhas on a very atypical topic. And now, what do you find out of this picture here? First of all, the basics: the attenuation, enhancement, shape. Shape is more or less kidney shape. Attenuation low, enhancement low. But there is if you look at the tumor, it is in continuation with the renal pelvis. If you look at this part, the renal pelvis, ureter, and this tumor are almost homogeneous. This is a transition cell carcinoma, which is very advanced. There are lymph nodes here as well. Now, lymph node involving transition cell carcinoma are very poor prognostically. They are very advanced. Sometimes they can involve vessels. But to be precise, the renal cell carcinoma is 48 times more likely to throw thrombus, throw lymph nodes involvements, blah blah blah. TCCs are initially not that aggressive. They can be if they are left for a very long time. So, whenever you have a picture, a CT scan, shape, ball or bean, attenuation, look at the homogeneity, center of the tumor, where is it localized to? I will discuss why the center of this tumor is after my next slide. I will tell you a very important thing. But here, the tumor, here in the ureter pelvis, anything that goes into the pelvis and ureter is TCC unless proved otherwise. The other thing that I wanted to tell you, the large part of this is necrosis and bleed. So, if you look at this and the bladder, you realize the densities, then you can understand. It can be confusing if the TCC is too large and then we're dealing a necrosis in the tumor, but contour is maintained to the last. As I said earlier, IVC involvement is 14 times more likely in RCCs. And the mass in TCC is more central than exophytic. I told you they are ball type lesions, they are usually on the periphery, they distort the capsule. This is another picture from Anthony. This is the same paper. They have published a case series of very high aggressive TCCs involving the vessels, which is rare, that's why they published. If you look at the dilated calyces, sometimes they give the clue as to, not always it's possible to make a very clear-cut diagnosis, but dilated calyces, and always look at the pelvis and ureter. If the tumor is homogeneous, then it's TCC. Now, what are the radiology mimics? The intrarenal TCC, this is a new term, intrarenal TCC and the central
The
RCC.
last line, please.
Yeah.
Last line.
Yeah. You want to see something?
The last line.
Before this?
No, the last line here.
Oh, last line. Advanced TCC with renal vein involvement. Note the shape of the kidney. This is a renal vein involvement. This is an arrow here. This is from the same publication, Anthony Bibhas from Bellore. And I wanted you to know this new terminology. This is a paper pulled up from, this is actually multi-center study, but the paper was published by Raja from St. George's, London. Now, what they did, they collected few CT scans over 3 university hospitals, period of 6 months, 1 year, something like that. This first, the intrarenal TCC was a term first described by Hilar in 1841. They are basically centrally infiltrating TCC. It's a very advanced TCC. If you have a TCC arising from the pelvis or the ureter going into the center of the kidney, is a T3 involvement. It's very advanced. And they can be very confusing with the RCC, and that in the radiology terminology they say it's an intrarenal TCC. And they are very close mimics of RCC. Now how do you differentiate that? So this is the study I was talking to you about. 98 central renal tumors. All central renal tumors, you have a choice between RCC, TCC, depending on this characteristics that I am trying to explain to you. Intrarenal TCC can be recognized with high degree of accuracy. How? Look at this picture. Now, there is a tumor here. You always look at the tumor mass extending into the renal pelvis. Same homogeneous. This is a homogeneous uptake. There is no heterogeneity about it. They are low, not so enhancing, low enhancement, and located in the collecting. The tumor center is located in the collecting system. Renal shape is maintained. These are the points that you have to look at when you think of intrarenal TCC vis-a-vis the intrarenal RCC. Now this is the picture of contrast filled calyx. Look at the calyceal displacement. The white ones are the calyces. With the time, they have been displaced with a ball-like lesion. The center of this lesion is in the renal parenchyma and the lower calyx, not the collecting system, on the parenchyma. And therefore, tumor center within the renal parenchyma, the renal shape is preserved here also. It's an intrarenal RCC, can preserve renal shape, but can confuse you. But these are some of the very close mimics that one has to go through. This has a ball shape and probably at a later stage would distort the kidney, but the central ones can be very tricky and you have to use your judgment. So, if we sum up from the study, what do we learn? Solid, homogeneously enhancing, anything that is homogeneously enhancing mass, centered on the collecting system and extending into the UPJ. If it has gone to the ureter, even better. That is our TCC without much difficulty. So, you look at these keywords, homogeneously enhancing mass, centered on the collecting system, extending on the UPJ or PUJ, whatever you call it, if not the ureter, combined with focal calcification, focal PC feeling defect, preserved renal outlet, likely TCC. So, what are the wisdom pearls from this paper? Accurately locating the tumor center is very important. The radiologists do it. They can exactly place the tumor center. Is it arising from the parenchyma? Where is the center of the tumor? Or is it in the collecting system? The renal contour next. Look at the renal contour. and look at extension into the EPG and ureter. If there is an extension of the tumor into the EPG and ureter, likely TCC. Anything calcified, homogeneous or whatever, more likely RCC. I don't need to go through the staging, this is not the brief. And I'll just show you one more picture and then I'll summarize what we spoke about today. This is RCC, very advanced RCC with lymph nodes. And you can see it has distorted the shape, it has gone into the perinephric space. These are the classic ones that we used to get earlier, very advanced stage carcinoma. And it is very clear that there are lymph node involved. The vascular involvement also, as I said, there are, you know the levels, the level 1 renal vein, level 2, level 3 supra hepatic, and level 4 thoracic involvement of the IVC. Now IVC involvement, renal vein involvement are very common in RCC. They are not so common in TCC. TCC, you have a central TCC with a massive lump in a what you call a T3 extension, and the patterns are different. So if we sum up what we spoke about, enhancement, attenuation are features that we have to keep in mind. They are more built into the radiology program than in urologist, but really look at the homogeneity, number one, shape, ball or a bean. It helps you most of the time. Extension of the tumor. Is it going to the UPJ, to the ureter? Where is it arising from? Where is the center of the tumor? Is it in the collecting system or parenchyma? These are the 4 clues that you really run through your head before you make a diagnosis. Not all are very confusing. Most of them are throwaway because they are very distorting. The RCCs, which are by far more common, they are more distorting. You have a shape deforming or shape cancelling phenomena. But if you have a very homogeneous slice which is going into the pelvis or vice versa, think TCC. I would take questions if you have any burning questions. I did not discuss anything further on. There are too many speakers to talk on the upper track. So these are the radiology patterns that we look at. Thank you.